Hello, this is Dr. Chen from Joint Center International Eye Center. Today, I would like to share with you the topic of the conjunctival. After this session, I hope you will be able to explain the anatomy and physiology of the conjunctival, the common causes and manifestation of the conjunctivitis, and describe the clinical features and management of bacterial, viral, vernal conjunctivitis, and pterygium. Let's just have a quick review of the anatomy. The conjunctiva is a transparent mucosal membrane that lines the inner surface of the eyelids and the anterior surface of the globe. It is divided into pelvic burr, fonical, and bubble conjunctiva. The pelvic burr conjunctiva starts at the mucocutaneous junction of the lip margins and is firmly attached to the posterior tarsal plate. The fonical conjunctiva is loose and reductant. The bubble conjunctiva covers the anterior scleral and is cutaneous with the corneal epithelium at the limbus. Inflammation of the conjunctiva is the most common eye disorder worldwide. The cause is usually exogenous, but rarely it may be endogenous. Because of its location, the conjunctiva is exposed to many microorganisms and other stressful environmental factors. We may see patients with infectious conjunctivitis, which are caused by bacterial, chlamydia, or virus, chemical or physical conjunctivitis, allergic conjunctivitis, and conjunctivitis secondary to dacryocystitis or chlamyditis. Non-specific symptoms of conjunctivitis include foreign body sensation, burning, and tearing. Itching is the hallmark of allergic disease. Look at these pictures. The signs of conjunctivitis vary depending on the cause. Follicles are multiple, discrete, slightly elevated lesions, most prominent in the fornix. Blood vessels run around rather than within the lesions. Causes include viral and chlamydia conjunctivitis. In contrast to follicle, a vascular core is found in each of the papillae. Causes include bacterial conjunctivitis and allergic conjunctivitis. Chemosis means conjunctival edema is seen as a translucent swelling. Acute chemosis usually indicates hypersensitivity. Hemorrhage may occur in viral conjunctivitis. Hyperemia that is diffuse, beef red, and more intense away of the limbus is nonspecific in conjunctivitis. Pseudomembrane consists of coagulate exudate adherent to the infraconjunctival epithelium. They can be peeled away, leaving the underlying epithelium intact. True membranes involve the superficial layers of the conjunctival epithelium, so that attempt removal leads to tearing. According to the nature of the discharge, we can make a primary diagnosis. Watery discharge occurs in acute viral or acute allergic conjunctivitis. Mucous discharge is typically of chronic allergic conjunctivitis and dry eyes. Purulent discharge occurs in acute bacterial conjunctivitis. The most common cause of conjunctivitis-induced tender preauricular lymph node enlargement is viral infection. Acute bacterial conjunctivitis is a common and usually self-limiting condition caused by direct contact with lymphatic secretion. The most common isolates are Streptococcus pneumonia, Haemophilus influenza, etc. As we mentioned, symptoms of acute bacterial conjunctivitis include sudden onset of redness and a burning feeling in the eye. Signs are variable and depend on the severity of infection. We may find eyelid edema, hyperemia, purulent discharge, and sometimes peripheral corneal ulceration in severe cases. For viral conjunctivitis, the spectrum varies from mild subclinical disease to severe inflammation with significant morbidity. Epidermic keratoconjunctivitis is caused mainly by adenovirus type A, 19, and 37. The patients will develop pains in the affected eyes with tearing and photophobia. The contralateral eye generally will be affected 1 to 2 days later. In physical examination, we can find conjunctival hyperemia and follicles. Most patients have tender, enlarged preauricular lymph nodes. Severe inflammation may be associated with conjunctival hemorrhage and pseudomembrane. Punctate epithelial keratitis may also occur. About 6% of bacterial conjunctivitis resolve within 5 days without treatment. Spontaneous resolution of adenovirus infection usually occurs within 2 to 3 weeks, so treatment is sometimes unnecessary. Specific therapy depends on identification of the microbiologic agent. We can start topical broad-spectrum antibiotics while waiting for laboratory reports or give some antiviral agents for antiviral infection. Topical steroids may be required for severe membranous or pseudomembranous conjunctivitis. The patient can also use cold compresses to relieve the symptoms. Risk of transmission should be minimized by hand washing and the avoidance of towel shelling. Vernal conjunctivitis, also called VKC, is an inflammatory disorder of conjunctiva and the cornea, probably of allergic etiology. It is a recurrent bilateral disorder which often occurs on a seasonal basis, with a peak incidence over late spring and summer. Typically, the patient complains of intense itching. It can be classified into pelvic burr VKC, limbic VKC, and vis VKC. Pelvic burr VKC primarily involves the upper tarsal conjunctiva. It is characterized by conjunctival hyperemia and diffuse pelvic burr hypertrophy, giving a cobblestone appearance in severe cases. It may be associated with corneal epithelial erosion as a result of the close appendice between the conjunctiva and the cornea. In limbic disease, gelatinous limbic conjunctiva palpably can be found and may be associated with transient white cellular collection, Horner centrostomes. Mixed VKC has features of both pelvic burr and limbic involvement. We can manage VKC by applying cold compresses and anti-allergic eye drops. Combined action of antihistamine and mast cell stabilizers are helpful. In severe cases, we can consider topical steroids and immunosuppressive agents. A pterygium is a triangular fibrovascular subepithelial ingrowth of degenerative bubble conjunctival tissue over the limbus onto the cornea. It typically develops in patients who have been living in hot climates and may represent a response to ultraviolet exposure and to other factors such as prolonged dry ocular surface. Most small lesions are asymptomatic. Irritation and grittiness are caused by the drying effect at the edge due to interference with the precorneal tear film. The pterygium may interfere with vision by obscuring the visual access or induce astigmatism. There may be intermittent inflammation. Extensive regions, particularly if recurrent, may be associated with subconjunctival fibrosis extend to the fornix. They may cause restricted ocular movements. Medical treatment vary depending on the symptoms. Irritation may be treated with topical lubrication. Inflammation can be managed with lubrication if mild, or with a short course of topical steroid. The patient may be advised to wear sunglasses to reduce ultraviolet exposure. We can consider surgery for cosmetic reasons. Significant irritation or physical disturbance. Simple excision is not recommended because of the high rate of recurrence, about 80%. So ophthalmic surgeons often perform conjunctival autographing after excision to reduce the risk of recurrent disease. We usually take the donor conjunctival patch from the superior paralimbic region, which generally heals rapidly. In summary, conjunctivitis can be classified into bacterial, viral, chlamydia, and allergic conjunctivitis. Signs of conjunctivitis vary with the different causes. we need to identify the main differentiating features. Pterygium is a triangular fibrous vascular subepithelial ingrowth of bulbar conjunctival tissue. Surgery is indicated for cosmetic reasons, significant irritation, or visual disturbance. Here is the reference. Thank you for joining us.